Thank you, Chairman Wu, Ranking Member Smith, and the staff. Really very much appreciate the invitation to testify before you on the privacy and security challenges raised by widespread adoption of health IT. What we do at CDT is develop and promote pragmatic privacy and security policy and technology solutions for a health system that we really hope will be increasingly characterized by electronic health information exchange to improve individual as well as population health. And I also chair the Health IT Policy Committee's Privacy and Security team that Dr. Blumenthal mentioned, and I appreciate the thanks. We're in a very good place, I think, for making some progress on these issues. We know from survey data that the public is actually quite enthusiastic about what we're doing with health IT, but they also express in equal numbers concerns about privacy. You can't have one without the other. Essentially, privacy is not the obstacle to doing all of this and getting it done. It is the enabler. And we need to consider it that way and pay it serious attention. And clearly this subcommittee agrees, or you wouldn't have asked me here today in a hearing that's largely about standards. And we'll do some talk about security standards because that's where standards really comes into focus, probably less so on the privacy side. We do have the privacy and security regulations of HIPAA, and of course states have laws as well, and those are the baseline. But we're really changing the way we're going to be moving health information and setting up new infrastructures, and so we have to consider what we need to layer on top of what we've already got. And in addition, we're talking about health information technology, not just protecting health information, and so we need to think about the strong role that technology can actually play in helping us to establish a comprehensive and flexible framework of privacy and security protections that will build that trust layer that will enable us to go forward. As I mentioned before, we're in a much better place than we were a few years ago when we were arguing about privacy. We're still arguing about it, but we actually, the work that Congress did in the high-tech legislation has pushed us tremendously forward. And in addition, the financial incentives that are part of the high-tech incentive program give us additional policy levers to really push us into a better place with respect to privacy and security. We still do have gaps to address, of course. You know, this is not something that is ever done. We need to sort of be continuously paying attention to this. And so I'm going to talk a little bit about security, and I'm going to give some credit to one of my panelists from HIMSS. They did a survey fairly recently of large healthcare organizations that indicated that security is far less of a priority than we would hope. And this is for large organizations. And just to lay out some examples, fewer than half conduct the annual risk assessment that the HIPAA security rule requires. 58% of these organizations say they actually don't have security personnel, and 50% reported spending 3% or less of their resources on security. And again, this is a survey of large organizations and not small practices, although as you'll see in HIMSS's written testimony, they're doing this survey next. I think those will probably be some very sobering numbers, but they are a lesson for us. We really need to be quite serious about this. When you think about what the root is of the public's concern, a lot of it is about inappropriate access to records for which security is a primary gatekeeper. Now, we know that with respect to what an electronic health record has to have in order to be certified, there are functionalities that have to be present, and Dr. Blumenthal mentioned some of these, the ability to encrypt data, the ability to generate an audit trail, but there's actually no clear requirement to use these functionalities. The HIPAA security rule is very flexible. It says that some of them are addressable. Similarly, in meaningful use, you have to conduct a risk assessment and address any deficiencies. But here you have the functionalities in the record, and we're not being terribly clear with providers about using them. I think that is a major deficiency. We need to raise our expectations, certainly with respect to small providers. A piece of health data is sensitive no matter who's holding it. If it's a large institution or a single physician practice. But in terms of the level of resources that the smaller physician practices can put into this, clearly we need something that is scalable and something that works for them now with a glide path to greater expectations down the road. So I'm reaching the end of my time. My written testimony has a number of other gaps that I've discussed there, including the HIPAA de-identification standard. We're seeing an increasing emphasis on access to and use of de-identified data for a range of purposes. Certainly when data is de-identified, stripped of identifiers, it's much more privacy protective. But we actually don't have a legal prohibition against re-identification that we can enforce. And that's something that Congress could actually do to really help secure trust. Again, the de-identified data issue is a big one. HHS is doing a study. I think after that comes out, we ought to talk seriously about what the right next steps are. So I'm going to close. I had a really ambitious oral statement here for 5 minutes. As I noted before, this is assuring privacy and security to the level where we've got the trust of the general public in what we're trying to build here really is an ongoing commitment. And the fact that you've put privacy and security on this agenda, even 2 years after high tech, when there's a lot of people who said, well, didn't we do this already? Shows that that you agree, which is terrific. So thank you again for the opportunity, and I'm happy to answer any questions that you might have.
Thank you very much.